Okay.
Thank you, Alex. Good morning, good afternoon, and good evening, everyone. Welcome to our Global Network webinar. Before we start, please allow me to provide a quick introduction to the Global Network of Data Officers and the Statistician, for some of you who don't know yet. So this network is a facilitated professional online social community, and it was launched in October 2020. Currently, we have almost 1,500 members from national statistics systems, UN system entities, and other organizations, including resident coordinator offices and UN country teams. The aim of this network is to help national governments build resilient and sustainable national data and information systems for the full implementation of the SDGs through collaboration, knowledge sharing, networking, and technical support. So today's Global Network webinar is being recorded and will be uploaded to the Global Network of Data Officers and the Statistician at yammer.com/UNstats. So now I will hand over to our moderator today, Samnath from WHO. Samnath, the floor is yours.
Yeah, thanks very much, Yushi. So my name is Somnath Chatterjee. I'm currently the director of the Department of Data and Analytics here at the World Health Organization, and of course, associated very closely with the Inter-secretariat Working Group on household surveys, as well as this network. So thanks very much again for asking me to moderate this discussion today. And welcome everyone. I think we have a great session today, a topic that is clearly very much in the news. It's very much on the top of everybody's mind as people are constantly asking the question of, what is the magnitude of the COVID pandemic? How many people have been affected? How do we know how widely this has been spread, and so on. So we will hear about the UK COVID infection survey and the one-year experience from a couple of colleagues from the ONS who've been running this exercise. And you will also hear how they've been able to adapt to a very rapidly changing scenario, as all of us know. And not only that, most importantly, how this data has been used to actually drive decisions. So it's my great pleasure to introduce our two speakers today. So we have Ruth Studley and Sarah Crofts. Ruth joined the ONS in June of 2020, having worked in policy departments for a number of years in the UK before that. She's a member of the UK Government Statistics Service and has led a number of statistical teams across various sectors. She has a number of years of experience leading multidisciplinary teams working in health statistics and research. And additionally, she has led various health policy and health regulatory roles. Ruth has a particular interest in producing statistics and intelligence to actually inform decision making. Sarah Crofts has worked in the national statistics since 2001 and leads the dissemination and outputs from the survey that you're going to hear about today, the UK's COVID infection survey. She has many years of experience in population statistics, and more recently has played a crucial role in one of the UN Stats Commission's city groups, the UN Titchfield Group on Aging. Sarah led a range of statistical topics, including the international migration statistics, social survey data collection, and various aspects of the New Zealand and the UK censuses. She's a member of the UK Government Statistics Service and has a particular interest in communicating statistics. It's my great pleasure to welcome both of you, and over to you, Ruth.
Thank you very much for those kind words. I'm now going to attempt to share my screen, so bear with me for 2 seconds. There we are. Okay, can everybody see the screen with my slides?
Yes.
Excellent, thank you. So thank you very much for inviting us here today, and good day, good morning, good afternoon to you. As mentioned, I'm Ruth Studley, and I look after the COVID infection survey analysis team here in the UK. I'm really looking forward to talking to you all today to talk about how what we've set up in response to the pandemic and how we've adapted over the year, and also actually sharing some of the things that we have learned. So the first thing I really wanted just to talk about was how we've set up our survey. So we have a household survey which was set up to establish how many people across the UK have had COVID-19 at any point in time, regardless of whether they are exhibiting symptoms or reporting symptoms or not. So we were able to establish how many new positive cases there were every week, and how many people also currently had COVID, and how many people were demonstrating that they had antibodies for COVID-19. So this survey particularly looks across those areas in the community population, and it's worth being really clear right up front what we talk about by our community population. So this is people that live in private residential households. It does not include people in hospitals or care homes or other institutional or residential settings. So it's really what people in society at large will be experiencing. And at the start of the pilot study, about 12 months ago, the sample for the survey was drawn from the UK Annual Population Survey, and that consisted collectively of those who had successfully completed the last wave of our labour force survey, or one of our labour force survey boosts, and had consented to further contact for research. And what we did is we asked everybody who was 2 or over within each household to take part of the survey. So we have within household groups, and everybody was asked to take a nose and throat swab. We then take and so we are able to capture information then from people whether they are reporting symptoms or not. It also allows us to establish, this is a longitudinal survey, and therefore it allows us to establish people who have had COVID and then have recovered from it, or indeed have been tested negative and then test positive. And additionally, it allows us to understand the within household transmission. On top of that, for all adults aged over 16, about 20% were also invited to give blood. And those samples were then tested for COVID antibodies to indicate whether they've already had the virus, because as we know, many people were asymptomatic and therefore did not always know that they were positive. I should go on to say that over time, and we will come to this shortly, but we've now conducted over 3 million tests as part of this survey. So it's actually quite a large survey, as you can imagine. So a really critical benefit of ONS leading this survey is the framework within which we produce our statistics. Most importantly, we produce independent and trusted statistics, and our code of practice, our regulatory framework under which we provide statistics, was a critical component for that. So as many of you in other national statistics institutes, we are bound by our code of practice. And that's that framework that ensures that our statistics are trustworthy, they're good quality, they're valuable to society. And these statistics are the best available estimate with which we can measure the prevalence and the incidence of COVID across the UK. And absolutely critically to all of this, all our methodology and our approaches to how we conduct the survey are all transparent. what has been really critical within this, and I'm sure this will be the case across the world, is ensuring that our statistics are timely, and that is a key component of our code of practice. We listen to our users and we adapt to their needs to ensure that the statistics that we produce are relevant and reflect what is most useful to society. But a really, really key part of this is our independence from government to enable us to produce statistics which are trusted. So what's really important about this survey was the rate at which it was set up. It was established in days and not weeks. And the only way that happened was because of the ability of ONS to be able to, the experience it has in running big household surveys, but also because of the collaboration and partnership within which we were working. So the survey is run jointly with Oxford University, so Oxford and ONS are joint leads of this survey, but we worked with a wide range and continue to work with a wide range of organisations to set this up, to collect and process the data. So we use a number of people to collect the data on our behalf. We have other people who are testing our swabs and our blood tests. And back in those early days of when we set the survey up, it was really critical that we could get our the call centre set up very rapidly, that we were able to get the questionnaires posted to people, and all of those things done very, very, very fast. And we were lucky that we had people within the organisation who had those skills and were able to pull people together. So a really critical aspect of being able to set the survey up so rapidly was the collaboration we had with our trusted partners. I'm going to pass over now to Sarah Crofts, my colleague, who's responsible for the dissemination side of that, who will talk about much more about what our findings are showing and tell you a little bit more about the survey.
Thank you, Ruth. Thank you. Well, it's a huge pleasure to be here and hugely exciting to be sharing our experience with you all. I never thought when I joined national statistics that at some point that I would end up working in an area that is of such huge interest. It's the first area I've worked in on national statistics where everyone is interested in what I'm doing. Everyone right the way through from, you know, expert epidemiologists, virologists, immunologists, experts on infections and pandemics, right the way through to where you buy your newspaper or the hairdresser. Such a wide range of interest. And that presents a challenge for us in terms of our audiences. So we do sort of think of three audiences that through our communications and our dissemination of statistics relate to. But crucially, the survey was funded so that the government could make decisions, evidence-based decisions, that would obviously help the UK tackle the pandemic. So our findings that we provide to government advisors, scientific advisors to the government and government departments, we provide weekly data as early management information as well as what we publish, and that helps to inform various decisions about the pandemic. So data from our survey has directly supported that decision-making process in terms of the pandemic response. So we've had times of national lockdown in the UK, we've had times of regional lockdowns within England. And although I've referred to the UK, there's been independent pandemic response from Scotland, Wales and Northern Ireland. There has been different times. So a December lockdown was quite crucial. It was a difficult time because, of course, we had Christmas and people wanted to visit their families. We had the UK variant, which emerged in the autumn last year. So we very quickly tried to pull together information to inform those decision makers on what was happening with the variant. And then lastly, we had the roadmap. So the government announced a roadmap out of lockdown. So there's various stages and various criteria that need to be met every time one of our restrictions is starting to be lifted. So our data are really crucial for that. And you'll see on the slides, there's just a few of the sort of newspaper headlines, because everything we provide is, of course, hugely in the public interest. So we need to consider how we communicate there as well. Next slide, please, Ruth. Thank you. So, I mean, this is the classic chart that I'm sure every country around the world has something similar to this. It just shows our positive infections over time since we started measuring the pandemic. And what's interesting here is you can sort of see those waves. You can see the times where we've had very low infections. I'm obviously very pleased to report that more recently we're sort of back to the levels that we saw in the summer last year. And it does reflect, you can see the impact of the new variant in this, so particularly from around mid-December with that increase in infections there. You can see the impact of the vaccine rollout with infections coming down and the impact of the various lockdown restrictions that we've had as well. So not only is our data measuring the pandemic response and what's happening, it's also informing it. So it's a little bit circular in that respect. But hugely important that we continue to provide these weekly estimates, and it's a very sort of quick picture of turning points in the pandemic. Next slide, please, Ruth. Okay, thank you. So we are able through the survey, because it's a national level survey, within England, we've been able to break down into sort of sub-regions when we had sufficient data to be able to do so. So that was from around October. And these data really helped to inform that sort of local lockdown response. So those decisions about which parts of the country were showing sort of concerning signs of rising infections. So this snapshot that you're seeing here is sort of at the start of this year, when infection levels were at their highest that we have seen nationally since the start of the pandemic. And you could see here that there's a sort of band of darker colours in this map. So this particular map, it's interactive. This is a snapshot, so you can't see the live version, I'm afraid, in this presentation, but it is published. And you can see that changing over time. So you can, if you played it, you can then see the different colours and how they change week by week. So you can see which parts of the country seem to be declining in terms of positive infections, and you can see which parts of the country seem to be increasing in terms of infections. So that really helps to inform those sort of local level decisions. And then those line charts on the left here, they just sort of show the similar information for the larger regions of England, and just sort of how the pandemic has shown there. So in London, for example, you can really see the impact of the new variant from the autumn, and you can see it just sort of reaching a peak at the start of the year. The southwest, that's predominantly an area that is less densely populated. We tend to have an older population in the southwest, and you can really sort of see with that band of colours the impact of those sort of more city areas that are more densely populated in the higher infections. Next slide, please, Ruth. Okay, so the new variants were of particular interest. So from mid-December, the UK variant was the dominant one across the UK, and it still continues to be so. So this is a snapshot taken again at that same time period, at the sort of peak of our infections at the start of the year. And you can really see that new variant that we identified back in November started to increase and became that dominant variant that was driving that increase in infections that we saw. Now, we were in a good position because a lot of the information that we collect on the survey, there's other information that we analyse from it as well. So for those who aren't aware, when the swabs are processed in the laboratories, they sort of go through a number of cycle thresholds. And if there's a high viral load, then the virus and the positive result is achieved after a small number of cycles. It doesn't need to cycle very long for the positive result to pick up. Where there's a case of a low viral load, then it will take more cycles to pick that up. And these cycle thresholds are known as CT values, and that's something that we regularly monitor as well. So what we were finding was that from that sort of autumn time, we were starting to get quite a lot of our positive results coming through with very low cycle thresholds, which meant that the viral load was quite high. Combined with that, we were able to look for the presence of 3 genes in those swabs that we were analysing. And we also realised that there was an increasing number of cases that tested positive just for 2 of those genes and didn't test positive for the 3rd gene, or the S gene. So that combination of high viral load, that sudden change that we saw, and the swabs testing for those presence of those 2 genes, and it was very localized in specific areas. So that gave a very early indication that there was a new variant that we were seeing and being able to do that. So I think the very first case we saw was sort of around the 18th of November, and we started to report on it from the beginning of December, when we were confident that we were looking at a new variant here. So they are PCR tests. I just saw that little question pop up in the corner of my screen there. We reported weekly, and this was the primary source of evidence for the government in introducing a sort of stricter lockdown in some areas over that Christmas period. So although there have been announcements that, you know, it was hoped that people under some sort of conditions might be able to meet around Christmas, some parts of England were placed under Tier 4 restrictions, which was a much sort of stricter lockdown because of the information we were able to provide on this new variant and how transmissible it appeared to be. Next slide, please, Ruth. Thank you. Okay, so as Ruth mentioned earlier, something that's really unique about our survey in terms of other data sources within the UK is that we have this longitudinal testing of participants in our survey, regardless of whether or not they report symptoms. And so we were able to see that around half of people, or slightly under half, were testing positive with no reported symptoms, and that really helped to inform the understanding of how the virus could be spreading. But it was also a really important public message that just because you don't have symptoms does not mean that you do not have the infection and therefore couldn't pass it to others. So that was a really crucial message to get out there. Also, at the start of the pandemic, it was widely understood that the symptom that you had to sort of watch out for was whether you had a temperature and a persistent cough. And that seemed to be the message, that if you developed these symptoms, you could then go and get tested. But what then we discovered through the survey was that there were other symptoms as well. For example, the loss of taste and a loss of smell. More recently, our main sort of reported symptoms have been a headache and fatigue, more so than those sort of classic symptoms that we all understood at the start of the pandemic. So this sort of helped more people to be tested because we were able to give more information about the symptoms. Therefore, when more tests became available, there were more people going and getting that sort of official test and then following the recommended guidelines about isolating at home and not mixing with others. So potentially it did sort of help through this information. It helped people make informed choices about whether to proactively get themselves tested and take the appropriate steps afterwards. Next slide, please, Ruth. So as Ruth mentioned, we had our initial pilot, which was a smaller number of participants. So now we go to around 150,000 respondents per fortnight across the 4 countries of the UK. And as I mentioned just now, something really unique about our survey is we're having to sort of continually adapt it and recognise what's happening in the pandemic and where evidence is needed and how our survey might be able to provide that evidence. So although we carried out those blood tests from the start of the survey to measure antibodies, there was obviously a huge interest to measure the impact of our vaccine programme. So we stepped up our testing of the presence for antibodies, and we moved to a finger prick blood test, so a little bit like that sort of test that some people do to check for blood sugar, which made it a lot more sort of accessible to participants, and they would finger prick themselves under supervision to be tested for antibodies. So that meant that we're stepping up to regular antibody testing of around 150,000 per month. Next slide, please, Ruth. So because we're sort of continually adapting, what this survey allows us to do is to obviously collect other information that again can help to inform either government decisions or people's own decisions around the risk. So the impact of face masks, for example, we've collected information on contact people have had with others, information on occupation. There's a whole host of different characteristics that we collect information on, and that allows us to be able to look at people testing positive and look at some of those characteristics of people testing positive. So one example where it has informed a debate was with the different sort of lockdown restrictions. Obviously, there have been times within the UK that schools have been closed to all but essential sort of key workers, children, and when the discussion was taking place about the reopening of schools, there was huge interest then as to whether people working in the education sector could be more likely to pick up the infection than perhaps some other occupations. So that was a piece of analysis that we did earlier this year that looked at the sort of the risk of testing positive by different occupations. And that was of huge interest, and for those who are interested, it showed that working in education was no more risky than the majority of other occupations. Okay, next slide, please, Ruth. Okay, so I don't expect you to read the words on this at all, but this is the main way that we sort of disseminate information to the public. So we do share early management information within our code of practice guidelines that really help with that operational decision making. So that's making sure that those government advisors and people working in the relevant government departments have access to pre-published early information to just start informing those discussions so that quick and responsive decisions can be made. But there's huge public interest as well. So we have a number of different products. So we produce weekly, a weekly bulletin on the latest infection rates. So that gets published at midday every Friday. We also, on a fortnightly basis, so every 2 weeks, we publish an article on some sort of characteristic of people testing positive. So this is where we published information on occupation. We look, this week, we've got information going out on symptoms, and whether people are working in patient-facing roles or non-patient-facing roles, and contact with others as well, whether that's physical contact or socially distant contact. That's another topic that we regularly report on. We also, on a 2-weekly basis, we report antibody data. So again, broken down by certain characteristics. Particularly by age. The vaccination programme has been prioritised for people in older age groups first, and you'll see a chart in a couple of slides' time where you can really see that impact of the older people. We do also record data in the survey on whether or not people have been vaccinated, and we record whether they've been offered a vaccine, whether they've had a vaccine, the type of vaccine that they've had. And in time, this will allow us to sort of do analysis on, whether people subsequently do pick up the infection, what vaccine they had, and how much time has passed since then. But what it doesn't do is provide the absolute latest numbers across the whole population of the numbers of vaccines that have been issued. There's a government dashboard that provides that information. But by us collecting information on vaccinations, we're able to sort of join it up with other characteristics and to sort of pick out patterns about the vaccination programme. We also publish all of our methodology, further information, because the modelling that we use to produce our estimates, it's quite complex for the public audience. We use a Bayesian approach, and so we do need to be, as national statisticians, we need to be very transparent about our methods, and to clearly explain how we arrive at the figures that we do, and any assumptions that have taken place to produce those figures, and any particular sort of quality information that also needs to be said. And then lastly, we also publish blogs from time to time. So these aren't a regular publication, but if there's a particular message that we want to get out, sometimes blogs are quite a helpful way. So recent ones relates to when we discovered the new variant and how we were going to report on that new variant, to just explain what those cycle thresholds mean, to just explain about the presence of the 3 genes that we test for in our antibody testing, and how we were able to identify the UK variant. And then another recent blog has been about antibodies and immunity, because what we were seeing with some of our antibody data is, particularly among the oldest age groups, we were seeing a rise in antibodies as they were receiving their first doses. But then a couple of months later, we were starting to see levels coming down. And that doesn't necessarily mean that they don't have immune protection from the virus, because there are other parts of the immune system that also offer protection. So we felt that that was a very clear public message that needed to go out there, because we didn't want to sort of create through our data a misleading message that the vaccines weren't working, for example, just because we were starting to see some levels of antibodies coming down. Next slide, please, Ruth. So this is the data visualization that we use. So this is people testing positive for antibodies. And you can see as it scrolls through, you can see the changes in ages. So as it started, you can see the older age groups rapidly increasing in antibodies. And then during March, you start to see it come down a bit in the very oldest age groups. And then they're getting their second doses, and you can see it going back up again. We're very transparent about the fact that these are survey-based estimates and they have uncertainty. So all of our visualizations, we do include the sort of the confidence intervals or credible intervals, just to show that sort of level of uncertainty in our data. And they're particularly important when you're comparing time periods. The photograph on the left is one of our Downing Street press briefings, and we sort of warmly refer to this chart as the nation's favourite chart, because it was one that has been shown a couple of times at these Downing Street briefings. There's our health minister there, Matt Hancock, and Jonathan Van Tam, who were talking through these data. So this is a chart that has been particularly popular, and yeah, one we're rather proud of, I think. So I think that's fair to say. Okay, next slide, please, Ruth. Okay, and then another dissemination that we have is something we call our Insights tool. So this is something that is updated several times a week, and we introduced this in December, mostly because for the public audience, if they're interested about the pandemic, there seem to be a lot of different places that they could go. So this was a way of just bringing it together. So this includes not just ONS data, but data from other government departments as well. So if you want to know about infections, you click on the infections tab. The screenshot here is the antibodies tab is selected, and you just see what the latest picture is of there. So what we're seeing here on the antibodies tab is the number of adults testing positive for antibodies. And then just for context, we've also put in the percentage of adults who have received 1 dose of vaccination, and then those who have been fully vaccinated as well. So it's just a real sort of snapshot for a public audience to be able to just quickly go and see what the latest data show. And there's different ways of breaking that down. So we have a latest headlines and an overview tab. So you can just very quickly think, right, on one page or a screen, you know, what's the latest data? What's happening with the pandemic? Are infections going up or going down? Which parts of the country are affected? Antibodies and hospitalizations and deaths. So, you know, what is happening in a real snapshot. And then if you want to know more, you can then sort of click on those other buttons there, which takes you down into more detail about those particular topics. And I think that was it for my part of this presentation. So I shall thank you for your time so far, and I'll hand back over to Ruth.
Thank you, Sarah. And I'm mindful of people's time, just to say I just have one last slide to wrap up and to share some of the lessons that we have learned over the last 12 months. And I think, you know, I've looked at some of the comments in the chat box, and I think it's probably worth just reflecting some of them here. So, you know, the pandemic has it moves so fast, and the user need as such therefore moves very, very rapidly as well. So one of our challenges was ensuring that we did always stay relevant. How do we make sure that we were able to respond to that growing demand for information, both by government but also by the public and by the experts? And that was absolutely critical, that we could keep on top of that. And I guess the thing to add is that there will always be more people who want more information than you can supply. So it's about ensuring you understand what those needs are, not just that, you know, who they are, but what and why, and what will the impact be. And linked to that, Sarah has given some superb examples of how her team has really helped make this data so accessible to so many people. It makes such a difference. And as Sarah said at the beginning, actually, when everybody is talking about this in such such a lot, it's so important that the facts that they have at their disposal are accurate. So making some of this very technical information accessible was a challenge, but something that we really recognised was critical. As with all high-profile statistics, the opportunity to bang the drum for the statistical frameworks under which we work was great. So we really did take the opportunity to promote the code of practice, and we helped use that as well in our planning arrangements, thinking about our users, thinking about relevance, timeliness, and the other aspects of quality. So that was very, very important. As mentioned early on, we are doing this in partnership, and the partnership with academics has been absolutely key here. And we can't underestimate how much they contribute to the whole process. We all know the value of a diverse workforce, but actually here what this also did was allow us to maximise the people who were working collectively on the survey, but the techniques that we had and that we were able to bring to the table, and how we could learn from each other, but also understanding each other's roles and responsibilities. So working in a National Statistical Institute, we have a set of roles and responsibilities to uphold. And working in academia, there are similar but sometimes different sets. So working through early on, what are the really important things and who is going to focus on what was quite an important lesson for us to learn. But linked to that, and something that the academics played a really important point with, was helping us innovate, making sure that we could still use new skills, that we were looking at the methodologies that we were using, and also challenges some of our dissemination techniques sometimes. You know, all of this was really, really critical. I cannot oversell the importance of that partnership working. It really helped us develop the skills in the teams, but also as people will move on in their careers, they will take those skills with them. So there's lots and lots of transferable skills there. So lots of opportunities to really push forward. I am mindful of time, so I'm going to wrap up, I think, because otherwise we won't have enough time for questions. But I guess the last thing I would say is that, you know, this has been a truly exciting 12 months from a statistical perspective, responded to something which has been a global challenge. And I guess the key driver that's underpinned this and the lesson that I would take away is the people that are involved in this are absolutely critical. You need to have people around you who are passionate about their work, who are really keen to challenge, who are keen to deliver and really understand the bigger picture and get so much pleasure from wanting to make a difference. That desire to do, not just produce some statistics, their desire to make the difference, to influence, I think has been absolutely critical. And I certainly know that I've been extremely lucky in the people that I have worked with, both within the ONS, but actually much more broadly across those partnerships. That's what's made this work so well, I think. And I'll close there and I can see. Thank you. Thank you all very much for your time.
Thanks very much, Ruth and Sarah. I think this has been a fascinating presentation, and I'm sure, as you would have seen, Ruth, already, there are several sort of, people are very engaged with this thing already, and I'm sure there are several questions. But maybe I can pose some of them to you and Sarah first, and then maybe if people have additional questions, they can, I think Alexander can perhaps unmute them and they can ask the questions directly. But I think some of the questions sort of have to do with the design of your survey in terms of, you did say that you've had about over 3 million tests that you've already done over the course of the year. And so people were wondering sort of what has been your total sample size thus far, what has been your response rate, what kind of consent did you obtain in terms of, I guess, feeding back the results, both in terms of positivity or in terms of, the variance that you're seeing. So were these things taken into account in the consent? And then I guess there was this question about the methodology. Let me just sort of ask you these methodology questions together so that you can address them. Maybe it's easier then. And also there was this issue around, Sarah did mention about the PCR, but you have been obviously, doing antibody testing over a period of time. So I'm assuming, this is my assumption here now, that you, did ELISA over a period of time for the antibody. So was this a quantitative ELISA for the IgG antibody, or how did you do that? Because people were also sort of asking for the practicalities of this, how did you do this? You did mention your collaborating labs in Oxford where this was done. So maybe if you could respond to, you or Sarah could respond to some of those questions first.
Of course, we'd be delighted to. So let's go back to the survey design. So yes, we get explicit consent from everybody that takes part, is the first thing to say. And because this is a research study, we have a protocol. The protocol is published, so we can share the links to all of that information if that would be helpful. Everybody is explicitly asked to take part, and the way that the design works is that where people were sampled, because it's a longitudinal study, people were tested weekly for about a month and then monthly for about a year, and some of that will be slightly longer and slightly shorter, but if I just take that as an approximation. But it is important to note it's the household that's sampled, and then everybody in the household is invited to take part. They don't have to, but they are invited to take part. And so the sample size grew from what was about, I think it was under 20,000 12 months ago, to us realising that actually there is a huge opportunity here. And then over the course of the summer, and then until October, we upscaled to get so that 150,000 people every fortnight, and some of those were weekly and then moved on to monthly. And so that's how we got to the 3 million tests, because obviously within a household there will be a number of people ranging from 1 to, you know, over 5 or 6 in each household. So that's the first point to cover around the survey design. And again, all the details in our methodology documents and our protocols, which if we send a link, perhaps you can attach to whatever is circulated. With regards to the testing, yes, they are PCR tests. So what happens is that we have survey workers, field workers, who go out to the household, and they are self-administered PCR tests but under supervision, and then they are taken away back with the field workers to the labs for processing. And I saw the question around, and the same with the blood tests. However, I saw the question about whether it was a binary response. So we do have a binary response to the antibody test, but obviously it is a sliding scale. It is a continuous test. And Sarah's written a blog on this, so I will let her come in on some of the big questions around that, because I'm mindful that somebody could just be under our line for saying whether they are positive or negative for antibodies, but that does not necessarily mean that they don't have them. Sarah, is there anything you want to add from your findings?
I think you've mostly covered it, Ruth. I mean, that was a very clear sort of part of our communication, was that in testing for antibodies, it is a binary response, but as Ruth mentioned, you get different levels of antibodies. So it was a clear communication that somebody could still have antibodies, but it might not have met the threshold to be classified as positive from our test. And that's something we're very clear to communicate, particularly in those who, you know, have had their first doses, haven't yet had second doses, or even over time, even after they're fully vaccinated, if antibody levels start to come down, it does not necessarily mean that there are no antibodies and that there won't be immune protection.
All right, thank you. So there were a couple of other questions which I think you did actually mention, Sarah, in your presentation, but I guess because you were also pressed for time, maybe you didn't quite get across, but maybe you can use this opportunity to now respond more clearly in terms of, you know, can you give a very concrete example of how your study was used to actually track disease progression, as well as used to inform some specific decision making?
I think that the main example that would spring to mind would be the UK variant and our measurement of that, because initially we saw that in the southeast and London, and you could see as the weeks progressed, we could see it then moving to the East Midlands. We could then see it moving to other parts of the country, to the point that it eventually was in all English regions and all UK countries as the dominant strain. So that's probably the most obvious example that springs to mind of where our data did inform sort of the pattern of the pandemic and what was happening. Yeah.
Yeah, and you did mention, of course, that, you know, your study did inform some of the lockdown decisions more directly, so it actually did have an impact on the ground as well. Then there was this other question, sort of, you know, related to, you know, typically official statistics does not perhaps use a whole lot of modeling, but you did mention in your presentation, you know, about some of the complicated analytical approaches that have been used using these, you know, Bayesian methods. So there was this sort of question related to that, you know, what challenges did you face as the ONS when you are using, you know, a sort of complicated modeling approach for your analyses?
So I'm happy to give an answer to that, Sarah. Feel free to jump in. It's a really interesting question, actually, and I'm quite glad it's been asked, because they are complicated techniques, and I think that's where that partnership really comes to the fore. So we are working with, you know, really well-renowned professional epidemiologists, academics who are really at the top of their field, and working in partnership means that we can really therefore exploit the methods that are available to us, and share those. And so the challenges that we face have been making sure that we can be completely transparent about that. And Sarah mentioned about ensuring, you know, how we get that information across, but recognizing those different personas. And actually there will be experts in the field who will really want to have the challenge around, for example, the INLA modelling, whereas there will be other people who just want to actually know what's happening, and trying to be able to balance those two and be able to describe some of those techniques in a in layman's terms. That's one of the biggest challenges we face, and obviously ensuring that we can upskill ourselves and learn to challenge and know when the right techniques to use are and when they're not. And as I say, that really stems from that partnership that we have with our different academics, I would argue. Sarah, is there anything you would like to add?
No, I mean, if you weren't here, Ruth, I definitely would have said that's the strength of our partnerships, because I think for any national statistics organisation, we recruit statisticians, we recruit analysts, we recruit social researchers, we recruit economists. We've never had a policy of recruiting epidemiologists. So it's absolutely crucial that we reach out and form those partnerships with the experts out there. And by partnership, it's a very active, real partnership. We have daily meetings and daily contact with these people because we produce on such a rapid weekly cycle. They are involved at every step of the way, from us thinking through the new methods, our prioritization of what we look at, our interpretation of the data that we're seeing, the quality assurance of what we're seeing, just to give us confidence, you know, in our methods, that we are tapping into that real expertise, and we're not trying to solve problems that we're just not skilled for as a national statistics office.
Yeah, thanks very much, Ruth and Sarah. So I just had a follow-up question, you know, just out of curiosity. Are these data, so the micro data, publicly available?
Yes. So we publish everything that we can that protects the disclosure, that doesn't allow disclosure of individual information. So we are very transparent around that information, and take that's quite seriously, actually, because we are mindful that there will be people who want that level of information. And linked to that, I'm mindful that there's a question in there which I could answer directly quickly around response from Danny, that says, so we publish all of that information as well, because actually one of the things that we are mindful of is that over the course of the 12 months, I talked earlier on about how we sampled from existing ONS surveys and we moved to address-based. We were very mindful that actually sampling from a cohort that hadn't been previously sampled might elicit a different response. So therefore we adjusted how many people that we sampled to start with, but at the same time, because of the effective comms that we have around this survey, people actually really wanted to support us, and so we have maintained and achieved that 150,000 a fortnight on an ongoing basis, actually. And that, as I say, that's partly because we had some clever modelling with a little m, a clever modelling to work out how many we needed to contact to start with, all randomly sampled and selected, but also using good communications about what it does. It meant that every family in the country, every household in the country was able to feel like they were doing their bit, actually.
Yeah, good. Thank you very much. So maybe we have about actually less than 5 minutes left, but maybe what we could do is, you know, there are over 300 people on this call, so maybe there might be people who want to actually put up their hand and ask you a couple of questions. So maybe we should give them an opportunity to do this. So if anybody would like to actually ask a question directly, please raise your hand. Alexander will unmute you and you can ask your question. Is there anyone, Alexander? I can't see on my screen. So if there is anybody who would like to ask a question.
Can I, hi Somnath, just, sorry,
yes, sure,
just quickly, because it's just right after Ruth's response to the response rate. The other day I was on Twitter looking for COVID impact surveys, and there was this exciting respondent showing a picture of the COVID infection survey questionnaire. Said, "I'm so excited that I got selected to respond to the COVID impact survey for ONS." So just to, this is not a question. Yes, thank you so much, everybody.
Thank you.
Yeah, sorry, I was struggling with my microphone, so I didn't really unmute myself. But I guess now you can hear me. I see two hands up. One is from by Mark Iliff, and then I have Asa Mohammed. Mark, please.
Yeah, so let's go with Mark. Mark also had a question about the geography, so go ahead.
Thank you. Yes, I'd be to follow up to that question. I'm just, as somebody who has been taking your data and explaining to my parents that live on the border between Leicestershire and Nottinghamshire, that just because Leicester is relatively green, you shouldn't be going into Nottinghamshire, mother, on the bus. I'm just wondering how you are dealing with the statistical geographies internally, because I appreciate you need to disseminate through to counties, so you've got something that is understandable, but these do not often make sense when you're dealing with these instances, because they're effectively cookie cutters. So what are your statistical geographies that you're using internally, which then will be presumably aggregated to create the dissemination geographies? Thank you.
Thank you, Mark. So we produce information down to a regional level, which are very well defined areas, and then we were producing the sub-regional information, which Sarah showed you some charts on, and they were developed with our geography team at ONS that allowed us to create areas which were essentially either coterminous with local authorities and counties, or actually had similar numbers of people within them. All of those, again, were transparently shared. So we shared what they look like and the data that underpinned them. And we are mindful, of course, and I believe the modelling takes this into account, that these are artificial lines, aren't they? Exactly as you say. How do you account for the fact that you're crossing a border when actually, you know, it's just a line? So we do take that into account through the modelling. Does that answer your question, Mark?
I'm just curious of like what the background in the background on the geography in terms of how you're presenting the statistics to the population, but also internally, are you able to generate your own geographies that show this is where we think the density of cases are, as opposed to aggregating based on an arbitrary geography, which is due to the UK's administrative instances?
So the sub-regional ones were ones that we determined, and we determined them so that we could get statistics that were of a good enough quality to disseminate, but at a low enough level. You know, there's no point having something that's so granular that actually the credible intervals around it made them not as useful. So that's how we made that determination.
Thank you. So we are at time, but we'll take the other question, Alexander.
Yeah, we can still use a couple of minutes. So I would hand over to Asa Mohammed. Asa, please unmute yourself.
Oh, thank you very much, Alexander. My question, and thank you very much for the very informative presentations and for the great work behind them. one small question. What would be if you would give like a summary lessons learned from your surveys and experiences? What would be that one single most important lessons learned that you would share with us? Over to you, Alexander.
Sarah, Ruth?
So I think I would probably repeat what I said right at the very end. I think you need to surround yourself with people who have got a high passion to get this done and energy and enthusiasm, because the challenges are great, but they're not insurmountable. So it's about having that we can do this attitude. You will need some people to challenge you, because sometimes you do need to be pulled down, but you do need that overriding energy and desire.
I would say something very similar, that many minds are better than one, and to achieve what we have achieved would not have been possible had it not been for all those partnerships and the guidance. It's sort of blood, sweat and tears really for many people in creating what we have. But ONS on its own could not have achieved this. There's huge value in those partnerships. Yeah.
Okay, I still see two hands up now. So we have Devi and we have Danny. So maybe we can go in this order, and after that we would close the Q&A.
Yeah.
Okay,
So
then.
Devi,
Okay.
please go ahead.
Okay then. Sorry if my question is not directly to the COVID data itself, but more on the technical implementation of the survey. With such a huge number of sample size in the CIS, how do you allocate ONS resources between surveys? Because in my cases, my organization, BPS or Statistics Indonesia, has a lot number of surveys. So if we need to conduct a large survey, it means that another survey have to be suspended or cancelled. And so how you allocate those resources between surveys? Thank you.
So I can answer that very quickly. Having been new to ONS, I have been absolutely overwhelmed by the support I've had from the HR teams. We have recruited so many new people into the organisation to support this. A considerable amount of people who were already in the organisation wanted to work on it, but we have brought in quite a lot of new people, and it has made a huge difference. But it does feel, and I was talking to somebody recently, and they did say that it's been the year of the analysts. And I think that those skills are in very short supply globally, actually. But we've been very lucky to be able to recruit so well. It's not been easy.
Okay, just to make sure, is it the when you mention the new employees, is it temporary employees or permanent ones?
There will be a variety of contracts.
Oh, okay then. Okay, thank you for your information.
Thank you so much. And then I would hand over to Danny Pfefferman. Please go ahead. Can't hear you, Danny. So. Not yet.
Okay, so maybe we can close Alex.
Yeah. So, but I saw that Danny had a question about the response. Can you hear me now? Yes, please.
Yes, go ahead.
I was muted. You mentioned modeling. In what context? For what purpose did you use models? Now I don't hear you.
I'm unmuted too. So we use models in a number of different ways. So we use models to show our prevalence, well, it's positivity rates as opposed to prevalence, our positivity rate. We also use models to show our antibody positivity rates and the people who have responded positively to the vaccine questions. We are currently reviewing our model for incidence, but most of the work that we're doing is all based upon different models.
Yeah, thank you. So I think we are already 6 minutes over time, so I'm really sorry that we have to close, but clearly this is a topic which is of great interest. In the chat, Richard had posted the link to all the documentation, so do go and take a look. And if there are any further questions, please do write back. And Sarah and Ruth have very kindly agreed to actually respond to any questions that might come after this. So once again, thank you everybody for joining. And thanks Alexander, Yushi, and Howie for this wonderful webinar. Thanks very much, and bye for now.
Thank you very much.
Thank you, everybody.
Thank you so much.
Thank you.
See you next time for our next Global Network webinar, which will be taking place next week, same time. So see you there.
Thank you. Thank you, everybody.
Thank you to everyone.